This week on the Inside Athletic Training Podcast, we're joined by athletic trainer and founder of Athletic Heart, Joe Rogowski, and sports cardiologist, Dr. Matthew Martinez, for a deep dive into athletic heart and the growing importance of sports cardiology in professional sports. Enjoy the show. All right, Joe and Dr. Martinez, welcome to the Inside Athletic Training Podcast. We're excited to have you on today to talk all things athletic heart, cardiac screening, and things right in your wheelhouse. We'll get into a ton of that information and about how athletic trainers can learn from what you guys are doing and the important work. We'll talk a bit about the foundation, gaps in screening, learn more about the company of Athletic Heart, and much, much more. To start, Joe, let's start with you. Share a bit about your background with our listeners. I know you spent time in the NBA for quite a while, now working with Athletic Heart and doing some awesome work. But let's hear a bit about your background and how you found your way into this world.
Yeah, I appreciate it, Sam. Thanks for having me. Yeah, as you mentioned, I worked in the NBA for 20 plus years. I'm an athletic trainer. That was my background was ATC, CSCS. Worked with the Orlando Magic, the Houston Rockets. And then my last 8 years, I was with the NBA Players Association, working as a medical director for them. And, I sort of have an interesting background in that my master's was in cardiac physiology, which is not a typical background for an athletic trainer. And that really gave me a little bit of an insight into, screening athletes, what that should look like. And I think, Sam, as we always do as athletic trainers, we look at how things are done. And athletic trainers, I think just by our genetic nature, look at things to make it more efficient and streamline it and make a quality higher. And, that's just, sports medicine, because, we're dealing with such high caliber athletes. It has to be done at a certain level, and it has to be done efficiently and effectively. And that's, when I started looking in the NBA and in my own world of, hey, can we do cardiac screening differently than how we're doing it now? At the time, we're outsourcing everything at a clinic or a hospital, or if we were having people come on site, was a quality, the quality that's needed for, the sports cardiologists that they require. And so I really started going down that rabbit hole of, looking at that from an educational standpoint. And from that, I founded a company called Athletic Heart and became my new passion of filling that critical gap that's often overlooked, which is sports cardiology. And that's where I started meeting individuals like Dr. Martinez and some of the big sports cardiologists, and learning from them and saying, hey, what is missed? What are we not doing well in sports cardiology? How can we make it better? How can I make it more efficient? What's the quality that you need? What's different than how it's being done? And just going to these meetings and conferences and getting feedback from them. But then on another side is looking at the tech side of it, because that involves the engineering and the efficiency and integrating with different systems. Because again, if we're going to do it where it's convenient for the athletic trainers and Athletic Heart, what we've really tried to make it as convenient as possible for the athletic trainers is bringing it on site and saying, okay, how can I do this? Being an assistant athletic trainer, I remember having to schedule these appointments. The guys would miss the appointments. Then I would have to manually upload this to the EMR system, which would take a whole day of my life, trying to upload all these different studies. Like, how can I just streamline that whole process so all we do is hit a button? And we've gotten to that point where it's pretty efficient right now. And we were able to accomplish. And, we're constantly learning because sports cardiology every year is changing. Dr. Martinez is publishing the newest literature, so it's refining our screening techniques. And I think we're sort of on the front end of this, and we get this information straight from the sports cardiologist, so we could adapt it on the fly and provide the trainers the best quality that they need.
Mm-hmm. Yeah, that's great. We'll get into all the details about Athletic Heart and kind of the origin and the systems and why it's so necessary. But Dr. Martinez, you've worked with NBA, Major League Baseball, a ton of different stops for you in the sports world. Share a bit about your background and how you ended up working with Joe on this project.
Yeah, Matt Martinez. I'm a clinical cardiologist. I'm the director of sports cardiology for the Mayo Clinic Enterprise. I work mostly in Florida, but I do visit the other two sites as well, about 30% of the time. And I've been taking care of athletes for over 15 years. It's it's an important part of what I think is a missed opportunity for managing athletes. Player health and safety is absolutely all the things the athletic trainers do. We're talking about hydration and nutrition and all the orthopedic things, but player health, cardiac safety is really critical, and we've seen an evolution in the last 5 years. We've started using what we think is a comprehensive way to evaluate athletes, soup to nuts, and athletic heart is part of that. And it's not the only part of it, right? But it is an important part of the screening and the assessment of athletes.
Mm-hmm.
So
And
I'm
Dr.
excited to
Martinez,
talk to you. I'm excited to talk to you today.
yeah, we're excited to get your expertise today. I've had the pleasure of seeing both you guys speak at meetings in the past for the past couple of years. It's always super interesting, and we'll get into what you're doing in the real world, practical with teams. But I want to share some background for a lot of our audience might be athletic training students or younger athletic trainers. Dr. Martinez, share some background about cardiology in general with sports, the difference between EKG and echo and in the simple terms, and what kind of these tests you guys are doing is actually looking at.
So really important. There's first and foremost, the electrocardiogram is the electrical tracings that we get where they place those 12 stickies all throughout your chest and your body.
Mm-hmm.
ECG, EKG, they're the same thing. And that looks for electrical abnormalities. It can tell us what's happening for the electrical system. It gives us an idea of what might be happening underneath that in terms of heart size, thickness, but it doesn't capture everything. It doesn't look at the valves. It won't look at the heart arteries. It won't look at the big blood vessel that comes off the top of the heart, the aorta. That's what the echocardiogram is. That's an ultrasound. It's just an ultrasound. It's got some differences to it a little bit for how we do ultrasound elsewhere, but it's the same technology, looking at Doppler to look at the heart, and we can look then at the things the EKG doesn't see, the valves, the structure, the function, and gives us an idea that we know that the athletic heart is different using an EKG and an echo.
Right. And Joe, on your end, you worked with the highest level athletes in the world for years in the NBA and so much work there for you. At what point did you realize kind of cardiac screening is so important and underutilized? And was there a point in your time during your career where you had a moment that you felt the need to go out and do this, or what was that kind of turning point for you?
That's a great question. Sort of the point for me was, so I did have this diagnostic background when I started in the NBA.
Right.
And I remember it was my first summer league with the Magic, and we were screening our athletes before summer league. And I was fortunate because I had this access to all this diagnostic tools, and the requirement was for EKG. And I said, well, listen, we could do EKGs on all these players. And this is before I knew anything about echocardiogram. I was very new to that area. And I said, well, I also have access to echocardiogram. I was like, yeah, we could do both. To Matt's point, EKG looks at one side of the electrical side, and the echo looks more at the plumbing of the heart. And so I added the echo to that, and that was an eye-opening moment for me, because when I added that echo, we were diagnosing things that were not seen on the EKG that were pretty significant finds. And that was sort of the moment where I was like, well, listen, as an athletic trainer, I want to make sure it's comprehensive. And I started just going down that road of educating myself on, all right, what's the difference between these tests? What do they look at differently? How hard is this to implement? How do you implement doing an echocardiogram? And then I started looking at the quality. And that was a moment, during that summer league. And ironically, at the same point, one of the other NBA teams saw what we were doing, and they're like, hey, can you set this up for us as well? I'm like, yeah,
right.
Let me. Yeah. And so that was the second team that did it, and it just sort of grew from there.
Yeah, that's interesting how things were happening in your world, and it kind of just led you to a need for this, and you're the guy to fill that void, which is awesome. Joe, to piggyback off that, in the presentation, you guys talk about the blind men and the elephant concept, explaining how there's a lot of different pieces going on. How does that relate to the athletic trainer's role, and what can the athletic trainer learn about kind of this process from that?
Yeah, and sort of my my thought with that is, the athletic trainers, we connect a lot of dots. We're very good at connecting dots. We see things sometimes that the doctors don't see because they're in their world. And as an athletic trainer, you're working with management, you're working with the player, you're working with the doctors. That's just, the nature of our job. And, when it comes to, the cardiology side, I think that's a very important skill set to have, because whereas the doctor might say one thing, the team GM might say another thing, the player might say another thing. We, at the end of the day, have to figure out what's best for the player, for the team, and ourselves. We have to empower ourselves as well. And, that was sort of, the idea behind that diagram of, the athletic trainer being sort of the point person to connect all the dots. The agents are even, involved in that to make sure that our athletes are getting the best quality care possible. They're getting the gold standard, which is, what is needed. And also, we're protecting ourselves at the same time.
Yeah. And Dr. Martinez, one major piece of the presentation is kind of the screening gap. Data shows that a lot of serious conditions can be missed because of certain tests aren't finding those. In basic form, walk us through what that means practically. Why are some tests not telling the whole story for athletes when it comes to what you guys are testing for?
Yeah, so I see this whole process as really being player health and safety. We're looking beyond is this going to have a sudden death with the athlete, and more, how are we taking care of the entire athlete? So if we find something on one versus another test, it may not have an immediate impact, but it definitely has impact on their life long term, right? A knee injury may not end their career now, but it does have implications long term for them, and they need to be informed of that. So the electrocardiogram looks at mostly the electricity. It looks at common causes of sudden death, things like WPW or Wolff-Parkinson-White. It can look for long QT syndrome. Those are classically found exclusively by the EKG. It also gives input into whether or not there might be an underlying myosin or muscle problem. Hypertrophic cardiomyopathy, long considered one of the more common causes of sudden cardiac arrest in athletes. The EKG is the first step to give you an idea that something underlying may be abnormal, but it misses it about 9 out of 10 times based on what the data shows. About 10% of the time, it finds it only 9 out of 10 times. About 10% of the time, it will be completely normal, and the echo is the key. In addition, an abnormality on the ECG doesn't make the diagnosis. It just tells you there might be something happening underneath. It's the echo that makes the diagnosis. And then some plumbing issues, coronary arteries that are going in the wrong direction, anomalous coronary arteries, a dilated aorta, or a bicuspid valve, all things that can really only be found by echo. So you see there's overlap, right? So there's echo findings for coronary arteries, for bicuspid valves, for aortic disease, for mitral valve disease, all of which are normal by electrocardiogram that the echo only finds. So they're both important. And these are diseases that we know, the ones I just mentioned, on both sides, EKG and echo, that we have found to be associated with sudden cardiac death. So there's published data on this, and identifying those diseases then allows you to have a risk stratification process with the player, making sure that they are safe to participate, get them to an expert. So finding it doesn't disqualify them. It just gets them to the next stage. So screening is process one, evaluation, risk stratification, developing a safety plan. Do they need something high level like a defibrillator? Or is this something that's going to be adversely affected by continuing to play? And then we all need to have that discussion about whether or not we should do something more definitive. Sometimes they need surgery earlier than we would have expected. This allows us to make the diagnosis and then have a shared decision-making discussion. All of us know about it so that there's no hidden agendas. The players know it. The athletic trainers know it. I always think the athletic trainers want to know this because they're at the front lines, right? They're the ones managing the athlete when they come in with symptoms or complaints or concerns. And I'll be honest, I've been overly impressed with the relationships that the ATCs have with the players. Many of them have years and years. They know each other's families. They care about those athletes. They come with them to the visits. The coaches aren't there. Their families are there. The ATC is there too. So I think as an athletic trainer, they have vested interest in managing the athlete.
Yeah. And Joe, on the same question, when you talk to teams and groups and organizations about this and about the gaps in screening, do you find that most people are surprised? Do you find that there's a lack of attention? Do you find that obviously you're doing this to advocate for it, but do you find that people aren't paying enough attention to this?
Yeah, that's a great question. One of my big goals is with what I'm trying to advocate for is education, because I think that's an area that there's not a lot of education. As athletic trainers, I was never taught any of this in my school. Right. We learned the emergency action plan and that side, which is equally important to as what Dr. Martinez and I are saying, because screening can't find everything. But we're never really taught the nuances of cardiac screening and the diagnostic screenings, what tests find what, the reason why. And a lot of times it's what is your goal? Is your goal just to look for sudden cardiac death issues, or is your goal to look at all things associated with the heart? And an analogy I've started using with athletic trainers is, the knee, like looking at it from an orthopedic standpoint of a knee. Is your goal just to look at ACLs, which is probably the biggest thing, which is like a sudden cardiac death with the heart? Or is it also beneficial to also know, if there's a meniscal tear or a MCL tear, which isn't catastrophic, the athlete could probably play with that. But in, 2-3 years, is that something we need to address? Me as an athletic trainer, I like to be educated on that side of things. We're like, hey, this athlete has a meniscal tear, not an issue, but in 2-3 years, you might have to address it. Or if he starts having swelling or symptoms, I could look at them and be like, hey, you know what? I remember 2-3 years ago when we imaged this, he had a meniscal tear. So that's, I think that's a big educational standpoint that, I'm trying to help, the athletic trainers with is, ask questions. Now we have sports cardiologists like Dr. Martinez that are easily accessible to talk to them and see, hey, what are we missing? Can we do this better? What are your thoughts? So that, we're consistently educating ourselves.
Right. And Joe, on top of that, education can be a barrier to doing more. What are some other barriers that you're finding? Like you go into a program and, obviously cost is one, education, like we talked about, buy-in from the whole department. What are those barriers that you're seeing in terms of people not doing more of this?
Yeah. So, some of the barriers is bandwidth, that's one thing. And that's really I would say that sort of highlights the gap that I tried to help fill. A lot of teams, when I initially talked to them of like, hey, why aren't you doing this testing or this extra, the EKG and the echo, and a lot of it's at their clinic or the hospital, they just don't have the bandwidth. They have one echo machine, they have regular patients that they have to see. The cardiologists don't have the bandwidth to read all these extra echoes and EKGs. So that was sort of one of the main reasons I wanted to help fill that gap, because that didn't sit well with me. Is hey, one of the reasons we're not doing this is just because we can't. I'm like, all right, let me solve for that. Another issue is quality. What I've come to really appreciate from Dr. Martinez and the other sports cardiologists is screening an athlete's heart has very different qualities than screening someone like you or me at the clinic. There's specific nuances that you're looking for that I don't think is greatly appreciated. The differences. If you have the wrong reference point on an athlete compared to a sedentary person, that could be the difference between finding an abnormality and not finding an abnormality. We've seen that several case studies on that. So, quality, the bandwidth, funding, obviously, everyone's used to doing this testing through insurance, and that's, that could be a barrier sometimes, because trying to get, 20 to 30 athletes through insurance, that's not something that will go through insurance, to do a preventative. Right. So you have little things like that. The good thing is we've done enough of these situations with different teams, different leagues. And I think at this point we've seen it all. I say that, but sure enough, something tomorrow will come along that I'm like, I never thought about that. But yeah. Yeah.
And Dr. Martinez, on your end, Joe mentioned quality and how the athlete is different. We all know from working in this space for a long time that athletes are different. Their bodies perform differently. They act differently. What does it take for someone to become qualified to be screening an athlete? What do you see differently? Are there enough people like you out there to have the bandwidth to screen so many high-level athletes?
It's really important because the athletes are different. We know that if you use a standard algorithm to interpret an EKG or an echocardiogram from your regular hospital, who may be an elite level hospital, you're going to give people diagnoses they don't have. Because athletes have changes that look like they're an underlying abnormality that's actually normal for the athlete. Over the last 10 or 12 years, we've learned more about athlete ECGs and what's normal and what's not normal than we did in the previous 50 years. Mm-hmm. And we've said the same thing about echo. So the ventricles can be dilated normally. They can be a little bit thicker than everybody else's. They can function at a lower level of squeezing function, what we often refer to as the ejection fraction, but it's normal depending on what type of athlete they are and what their exercise regimen looks like. So that education is important. How do you become a sports cardiologist? Well, we wrote a curriculum a few years ago. It's still evolving. We're actually building a society right now that is been launched for improvement of how we kind of regulate who takes care of athletes and then, quote, certifies who has the knowledge base to do this. Because there is a distinct difference between using regular evaluators and using people who have expertise in this, just like there is in orthopedics and in ATCs. There's specific training for this. And I want to add one other part of this. So if you ask, some people will say, well, I asked my cardiologist and they said, we don't need echo. We just need EKG. And what's missed in that is what that cardiologist is actually saying, we don't do echo because you need a program, you need a process, you need expertise, you need sonographers who are experts, and then expert interpreters. That's what we've done in the NBA, Major League Soccer. The NHL Combine does this. They do this at the MLB Combine. So why aren't we expanding that to then cover all of the players? Why is it that if you go through the MLB Combine, you get evaluated completely, including echo, but if you go to if you don't go to the MLB Combine, you don't get that. So this is an opportunity to look at the entire process and say, what's the best practices for this? And for me, no one delivers it better than Athletic Heart. They have really refined this. They're basically throughout the entire United States and internationally. We're able to get this through their process. And it's because they've got multiple layers. They've got sonographers who are experts all over the place. They've got a test to make sure that they are complete and they know what those protocols should look like. Then they have interpreters for all the teams that all have to be vetted. And that process leads to best outcomes for athletes. So when we hear we don't need the echo, what they mean is that we don't need an echo for the entire athletic population. Everybody doesn't need an echo every year. But if you ask them granularly, that's those same individuals who are part of MLB and other professional organizations will tell you a one-time echo will show you more. And we do that for all the professional leagues, save a couple. And maybe it's time for all of us to look at what the benefits would be to identify all those players.
Yeah, and Joe, on your end, you guys have presented to PBATS members in the past, specifically with Corey Trumbull and the Marlins, about kind of the process, the importance, what it actually looks like in a real life environment for the athletic trainer. When you do it, is it spring training? Like all those details that go into you guys screening an entire organization, basically. And baseball is massive compared to basketball. Football is huge too. Talk about that process in general, maybe like piggyback off what I said about working with the Marlins. What does that look like? What do you do with Corey Trumbull and how does he operate? What's the relationship there?
Well, I will say baseball in comparison could be somewhat easier because it's
easier,
spring training camps in Florida and Arizona. Right. That makes life a lot easier. So that you got that right there. But, when we did the Marlins with Corey, Corey's very proactive, athlete health first, very innovative. I think initially we ended up screening some 200 athletes with him and just doing baseline echoes and EKGs on his athletes. And that was all during spring training. And what we do is, because to the issues that I mentioned before in terms of bandwidth and that is we were able to bring in 10 echo machines on site to streamline that whole process so that we could do a high volume screening like that. And I don't want to go into specifics, but I know if you were to ask Corey, we did find some abnormalities that were of significance to note and to follow up with. And I know their team doctor was very happy about that. And he was able to sit down with each one of those athletes and go through, the results with them and how to monitor and how to, every year what they need to be doing and that. So it's very impactful from that standpoint and a good test study working with Corey. And the whole department of the Marlins was very easy to work with. They all are like-minded and very proactive about health. Saw what they were doing with their emergency action plan as well.
Right.
They're just on top of it. But, baseball does have that advantage where they are, spring training, they are in 2 states. And they're there for an extended period of time. I compare that to when we screen Major League Soccer, which you have 2 days to do 800 echoes in 30 different cities. That's a little more difficult. And we do that. And we've been able to do that all in one day and get them all read in one day. So I compare it to that. Anything compared to that is easy. You just have obviously more players in baseball, which makes that a little, could make that more difficult, but you just got to scale it then accordingly.
But that's the process that separates. That's why we've stuck with them. And Joe knows this didn't come out of the box this easy. We've had a couple of bumps, maybe a little, Joe, over the years where we had to refine the process, not on his part as much as it was the entire process, right? Where they had to get used to this. And it was, well, we work at so-and-so university hospital. We're really good. I say, great. Well, we have to do them all day Saturday and all day Sunday. They've got to be done and read that same day with sonographers that have expertise doing this. And they say, well, we can't do that. Well, I know. That's why we do it this way. It's hard for a hospital to shut down what they do on a regular basis and do just the athletes for those days. Even the pro teams have trouble doing that as the one-offs because the hospital's in business to take care of communities and larger groups. What we're doing is just the athletes. And for those few days, it's all we care about. Yeah. And that may sound selfish, but for the MLS, for those 2 days, nothing in the world matters but getting those players to the point where we know that they're safe to compete.
And Sam, I think a part to that too, that often gets overlooked is the integration, the IT, the EMR side of it. Yeah. So being able to have all these studies read remotely, and that's where obviously from the medical side, that's a huge part of it and component of it. But a lot of times, a lot of the doctors, the cardiologists don't see the other side, which is the IT part of it, because that's not their area of expertise. But that's probably the heaviest lift of, hey, being able to put all of these studies on a platform that are read instantaneously by those doctors, wherever they might be. They might be on vacation that weekend. They could read these, shared decision-making. So if they had a question, they can immediately ask Dr. Martinez, hey, can you take a look at this? Well, Dr. Martinez is at Mayo Clinic. He could jump online, review it immediately, feedback to the tech that's doing the image. Hey, can you get this other image here? All in real time. And then when it's all said and done, it just automatically gets uploaded to the ARMS system, the EMR system, once completed, which takes is a big sigh of relief for the athletic trainer that they don't have to be involved in all that part of uploading it and making sure things get, all to the end part. So that's one area that I think often gets overlooked, but is probably one of the biggest parts of it.
Yeah. So Sam, the athletic trainers like it because if they get a new player and they've got old studies, as you know, getting that extracted from a hospital system requires a note from the Pope, right? This is no easy task. So what's nice about this is that if you get a new player and and this can all be transferred over electronically once the player, of course, allows that. And then if you're a cardiologist can then look at it, we just give them access. How long does that take? 20 minutes. And if they say, well, I'm worried about so-and-so, Matt, can you look at it? I say, sure, I can look at it too. They give me temporary access. So that advantage and speed, as you know, this is a quick motion, right? It's the players here. We want them. You evaluate them. We're going to sign them in an hour. You've got This has to happen quickly.
Right.
In the old days, we were missing stuff. They would show up, and then a few weeks later, something would show up, and I would say, look, it was there 2 years ago. Why didn't we know this ahead of time? Well, because it took us 2 weeks to get the records. Thankfully, those days are over.
Right. Yeah, that's awesome information there, guys. And Joe, you mentioned the 800 for the MLS in a weekend. Kind of mind blowing to think about that process, knowing a basic amount from hearing you guys talk. What did that teach you about how to do things, your systems, your processes, your experts? And Dr. Martinez, after Joe, I'd love to hear your thoughts on that as well.
Sam, and I will say that's where the athletic trainer in me really comes out, because you have to be so well. I mean, we've done it before where, if you do a high school screening where some of us started off, where you have like 300 high school athletes coming in to get their physicals and you have to station, you got to be the communication has to be really, really done well in advance.
Mm-hmm.
It has to be streamlined. You have to connect all the dots, and you have to have contingency plans and protocols if something were to happen. And now, thankfully, we've done this with MLS specifically. I think this is like our 6th or 7th year we've done this with them. So we've got, and every year we learn something new. We add a new part to that. And you're dealing with technology, and something's always going to go down with technology. You got to be able to troubleshoot that on the fly. But I really lean on my background as an athletic trainer because we've all been there where something goes wrong and you got to deal with it. You got to fix it on the fly. And there's no excuses. The players got to get out there and play in 20 minutes, figure it out. And that's where I've really been able to utilize that background to help coordinate these type of events. And also, obviously it's not just me. We have a whole staff of personnel that are all wired the same way. I really, I tell them, I'm like, you guys got to think like an athletic trainer, all my medical people. And they've really learned, hey, there's no excuses, has to get done, figure it out. And that's how the athletic heart model has sort of, I think, been successful because we all have that same mind frame. Mindset.
Sam, you're talking about the third rail of this, right? Where there's one thing to be able to do an ECG, another thing to be able to get an echo, and then another thing entirely about how you get access to somebody who is then going to be able to say, is this okay or not?
Right.
That is really critical. As you know, the athletic trainer then now is spinning because now we've given you, here's an abnormal electrocardiogram. The echocardiogram is read by somebody who says, I'm not sure, it's kind of borderline. And you say, yeah, except the coach wants him to play this afternoon. So, and you call your local group who says, yeah, we have a cardiologist. He can see you in 3 weeks. Like, well, I can't do it in 3 weeks. So this allows that system to already have it in place. We're ahead of it, right? One of the things we wrote about, myself and Jonathan Kim and Kim Harmon about this process is that it's critical that you identify a process ahead of time, that if you find something, what are you going to do with it? Do you have a way to get that player out of trouble? Because now they're in limbo and they say, look, I feel terrific. I have no family history. I've never been to the doctor a day in my life. And now I can't play because you told me the doctor is uncomfortable with the way my echocardiogram looks or the way my EKG looks. Maybe I shouldn't do this test at all. So creating that process and having it ahead of time is critical because we don't want this to be like the old days where this is an impediment to participation.
Yeah.
It shouldn't be in the way, right? It should be additive. The players should feel good about this process. I feel safer because I've been evaluated and I know that there's nothing striking. We know it's not perfect. Still need the AED, still need hands-only CPR. Absolutely the most important final common pathway. Can't predict that stuff. Even if the screening is normal, can't predict it. But we don't want this to be a hurdle that the athlete says, well, this is terrific. Thanks for holding me out for 3 weeks. I haven't thrown a ball in 3 weeks. Now what do I do?
Yeah. And Joe, on your end of things, when it comes to the athletic trainer in the club and like liability and things like that, when, players want to play and you tell them they shouldn't, how does that process work for the athletic trainer in terms of the reporting, doing things the right way, but also kind of like Dr. Martinez said, the battle with the player wanting to play and you guys, providing data and information that says maybe they shouldn't.
Yeah. And that's, I think, very similar to how we've progressed with orthopedics. There's doctors that we know in the sports world that you want your athletes to go see, because they have the bedside manner that you want working with athletes.
Yeah.
They have the knowledge, and they know how to present things to athletes. And so that's where I've really tried to help athletic trainers and let them know that, hey, use me as a resource for you guys. Like if we do find something, it's not the end of the world. There's a way to present this. Let's get the experts involved. And that's where I'll often refer to them, hey, why don't you have Dr. Martinez take a look at this? Here's his number, give him a call, or one of the other sports cardiologists out there that, I've met that, also have a good bedside manner with athletes. And that's very important, because I've seen where sometimes an athlete, their local cardiologist isn't versed in sports and what's important and how to frame and phrase things to athletes and the trainer and to the management of the team. And it sometimes does more harm than good. And then you got to scale that back and present it from a different way by a different cardiologist. And I've been on several cases of that where a trainer calls me and just all stressed out, and I said, listen, here's who give this doctor a call, talk with them, have the athlete, have their agent talk with them, and it ends up going a lot more smoothly. So I think that's an important part, is that that second layer of being a resource for the athletic trainers, just pointing them in the right direction of, hey, this is who you'd want to talk to for this situation.
Yeah. And Dr. Martinez, on that same note, I had Dr. Christopher Camp of the Minnesota Twins and also the Mayo Clinic on the show a handful of months ago. And he made a great point that he wants to establish relationships. He's not there every day seeing the players like the athletic trainer, but he doesn't want a player to think that when Dr. Camp walks in the door, he's the boogeyman and something bad is coming and there's bad news, and that's all he delivers. So he wants to establish good relationships. In your position, how important is that for the doctor or someone in your position to have a relationship with players and the athletic trainer? So, and learning how to kind of have a feel for the club and the athlete when they are presenting news that could be bad at times.
Yeah, I hate to agree with our orthopedic colleague on this, but Chris is spot on. So this is really important. So in the old days, right, the answer was, we're looking to evaluate athletes to find cardiac conditions to disqualify you. Those days are over, right? Over the last 10 to 15 years, we have spent an enormous amount of time building relationships so that athletes feel comfortable saying, hey, doc, sometimes I have palpitations, sometimes I have chest pain, and we don't want them not telling us that, because they're afraid we're going to come in as the boogeyman and disqualify them.
Right.
The opposite is true. I want to keep them safe. They want to be safe. I want to make sure that we come up with something that, even if we have a condition, we're not looking for a condition to disqualify you. We're looking for a condition to risk stratify you, make sure you're safe. By the way, if you need an ICD, are you disqualified? No, you're not. So there's a chance that we can find something, risk stratify you, keep you safe, make sure your family is comfortable with this. And I couldn't agree with Chris more that this is important, that the athletes feel like we're in this together, because we are. We're in this for player health and safety. For them, their individual player health and safety is the most important. I look at it more holistically, sort of a league and then an individual team process. But the goal isn't to disqualify, it's to risk stratify and then create a plan for that. And developing those relationships is critical. And if you don't, then the whole system breaks down. They stop telling you about things. They don't tell you about family history. They don't tell you that they started a new medicine. I've had people say, do me a favor, don't tell them, but I do a Red Bull or two every day. And I say, well, they all do. What do you mean? Well, that's not unusual. It's okay to tell us that. That helps me, because now I know the palpitations are probably related to that. Let's talk about maybe a healthier way to get your caffeine level safely and have that discussion. Yeah?
Yeah. Very interesting stuff there. I know a lot of our guests on the show talk about just the feel for the athletic training room, and those relationships and communication with players is so hugely important. Joe, shifting gears a bit here, we talked offline a bit about the colleges we attended, and not all of them were huge schools. For the athletic trainer out there who might be listening, hey, I'm at a small program. We can't afford to bring Joe and Dr. Martinez in. We don't have the resources to do any of this, but I want to. What do they do? What's the first step for those people?
Yeah, and that's a great question. And, I'll probably let Dr. Martinez answer this one. One of the things that, we see sometimes, that we always have to be careful about is, sometimes doing tests incorrectly is worse than doing no test.
Right.
So you always have to be careful about that, and you have to make sure you have the experience and the expertise and the personnel to do that before you start navigating that area. Dr. Martinez, I'll let you jump in here a little bit more on the overall screening.
Yeah, I think one size doesn't fit all. And I think it's an opportunity to try and engage us. And obviously, for anyone listening, I'm happy to participate in that discussion. But it may be that you have more resources than you think, that there may be somebody closer to you who is willing to do this. There may be nonprofit organizations that are able to do this correctly. Then we can create the back end process. So we have a nonprofit that does it well. We know that has the right equipment, who can get the electrocardiograms done. Then we need to create a process. How quickly can we get the echoes done for anybody that we find that's abnormal? And then how do we get you to see an expert? And do we do this? Do we include athletic heart in this as part of that process? Are they the one-offs? Are they there? Are they available in the city? So it is absolutely more doable than we think it is. It just requires a little bit more thought process. And then it's an opportunity to remind ourselves about screening, about emergency action plans, about hydration, and maybe we can build this as a citywide, a system-wide educational opportunity for all the athletes. And there's ways to get this done. People have more donors, more access, more availability, I think, than we all think we do.
Yeah, to that point, EKG has become pretty accessible now. To Matt's point, with the a lot of those nonprofits out there. I know, for example, like the state of Florida is now requiring all high school athletes to get an EKG, and there's nonprofits like Who We Play For that are out there that are providing those EKGs. Now it's just the secondary tests, getting the echocardiograms for those that are abnormal. How do we address that? And that's where a little creativity is probably needed, and it takes several people to come together and to figure out that next step.
Right. And guys, we obviously appreciate your time. I know you're super busy and we could talk about this for hours, but to wrap up today, Joe, I'm curious in your opinion as founder, and you've been so involved in many different sports leagues and throughout this process, what does the next 5-10 years, the future of athletic heart look like? What's your goal? Is there, a point you want to get to where you're satisfied with what cardiac screening looks like in pro sports?
That's a great question. I wish I knew that answer, because it's sort of drinking out of a fire hose right now with athletic heart. We keep growing with the leagues. And, something interesting that I didn't envision several years ago was, obviously I knew the athletes and doing the physicals was important, the preseason physicals, clearing the athletes. But what I've also seen is now, a group that we've often, forgot about is ourselves, the athletic trainers, the coaches, and the staff. And I've been pleasantly surprised to see, when we've done a couple teams where the athletic trainer said, "Hey, this is great. Do you mind doing just a screening for us trainers and the medical staff or the coaching staff, because we don't take care of ourselves. We all know that." That's sort of a pleasant benefit. And then something else that I've started to see is the retired players, the former players, where leagues have now said, "Hey, listen, these guys set the foundation for us, laid the groundwork for us. Let's not forget about them from a medical standpoint." So a lot of the leagues have had us come in and start screening retired players. So it's grown a lot in that sector, which I really didn't envision. And I think part of it obviously is because of the quality, and it's able to streamline the process where, for us, for a coach or for anyone, it takes several phone calls, going through insurance to get the same level of testing where, we could come in right on site and knock it out in an hour, and they could get the results. So that area, and we call that more of like the executive physical, has really picked up, and really been an added bonus to what we've been doing. So I see that area continually grow. My goal would obviously to sort of be the standard behind the scenes for the leagues in terms of just making sure the quality is standardized, and how it's being done is to the level that's needed for, this type of population.
So, Sam, this is another example of where one size doesn't fit all, right? The ECG in a 50-year-old is not the same value as an ECG and echo in a 20-year-old, right? So under 16, that conversation is a little bit different. Do they need to be repeated or not? There's a difference between a 13, 14-year-old ECG and a 18 and 19-year-old ECG. Normal changes that evolve, they go away, that look abnormal at 13, 14, 15 compared to 17 and 18. And then up to 30, you're looking for things you're born with, congenital diseases that we know put you at risk. And then what Joe's talking about, those of us who are over 40, some of us are over 50, who now it changes. Now it's a prevention conversation. Now we have to go beyond that. Should we be talking about what your habits are? What are your coronary disease risk factors are? What are your prevention? Should we be looking at interval thickness? And that's what the retired players do. And Joe's got experience in all of that. So we lean on him when we're talking about coaches. Now he and I have talked about it. It's now about prevention. Now we're talking about, hey, tell me about your sleep. Are you doing hydration? Do you exercise? Hey, man, looks like you smoke 2 packs a day. Let's have a conversation about that. You don't need the ECG. We need to have a conversation about prevention. And the way Joe's got it set up, I don't do any of the retired players for him, but they have a cardiologist there that then talks to them, provides the details for them, and then says, go back to your medical home. Take this to your doctors and make sure that you are safe with the information that you have. But as you know, finding a primary care doctor, finding a cardiologist to do all that testing is hard to do when you're a coach, you're an athletic trainer, right? So Joe provides that on site with an opportunity, the players all to get together. I always laugh at when Joe tells me about it. It sounds like a barbershop episode. All players come together and commiserate. Remember that time I took you to the hole? Remember that time I took you deep? All that sort of stuff. But it gives them a chance to get their health taken care of, things we usually neglect. And I think it's not a one size fits all. It's a unique opportunity for sure.
And that's where it helps, Sam, where I've been fortunate, again, being an athletic trainer, you've really got to be flexible and customize it to that population. So when we go in and do coaches, we screen a little bit differently the coaches than we do, say, the players, because we're looking for different abnormalities. And then, and it's been really eye-opening for me doing the travel party, the coaches, the athletic trainers, because, they don't get the healthcare that our players get, obviously. And we always, our secondary. And unfortunately, we're some of the most unhealthy people out there.
Right.
Coaching staffs are not, and those would be always the ones as an athletic trainer I'd be worried about when we're flying on a plane, of having, that's why I bring the AED on the plane, is for that population. Mm-hmm. So, that's been really cool to see is, the athletic trainers going, hey, great, you do our players. Hey, how can you, what about our coaching staff and our athletic training staff and our travel party? Can you do that? And we do the coaches every year at NBA Summer League. We do 150 NBA coaches. And every year we're finding we have significant fines. We had one coach that was an AFib when they came through and was immediately able to get treated there at Summer League, which was, a huge fine. So those are the little things that I really look forward to in the future of helping just promote that and educate people on that and be proactive about our health, whether you're a player, a coach, front office, or a retired player.
Yeah, I think that's a great point, Joe. And from your experience, the athletic trainer is not getting enough sleep. They're working too much. It's a very selfless profession, flying coast to coast, 162 games in baseball. It's a crazy world out there. And I think that's awesome that you guys are not just thinking about the athletes, but the people that serve them. I think that's really cool. Well, guys, thank you so much for all you do and educating athletic trainers about athletic heart and this process, an important topic. I think this conversation is going to help a lot of our members and younger athletic trainers better protect their athletes. So Joe and Dr. Martinez, we really appreciate it.
Thank you, Sam, for having us.
Thanks for having us on. Hopefully the beginning of this discussion. We have more to come in the future. Thanks, Sam.